live soon.
Okay, let me know.
Okay. Hello, web shadowers. Thank you all for attending our session this afternoon. Today we have the pleasure of hosting Dr. Chamarti, who will be teaching us about emergency medicine. As always, please remember that the Google form will be posted in the chat box and in the description of this video at the end. With that being said, Dr. Chamarti, you may start whenever you're ready.
Hi, everyone. My name is Siri, and you can call me Dr. Siri too. I am an emergency medicine physician practicing in New York City. I'm currently an ultrasound fellow. So I'm just going to introduce you to what this presentation will be about. So essentially what we're going to be doing today is we're going to be going through an introduction to emergency medicine, go through some cases, and then at the very end, I actually have my butterfly. So we're going to go ahead and do a little bit of ultrasound scan time. Okay, so an introduction to me, kind of my background. I'm originally from California. I went to school there, and then I moved to Georgia for medical school, and then I came to New York to learn emergency medicine, and I'm in New York still, and I'm currently an emergency medicine ultrasound fellow. So it's really exciting to be with you guys and share some of the cool things that are going on right now. What is emergency medicine? Well, emergency medicine is essentially a physician who takes care of immediate problems. So we take care of a lot of pre-hospital patients, hospital patients. We stabilize patients. We don't necessarily diagnose them all the time, but we definitely make sure that they're not acutely dying in the next minutes to hours to days, essentially. And if they are, then we make sure that they get the help that they need. So that's essentially what we do. What people think EM is, there's a lot of misconception about, I think, exactly what emergency medicine entails. Not always are we doing the fun, like sort of resuscitations and chest tubes and intubations. A lot of EM is actually just talking to patients, figuring out solutions to common problems. And a lot of the times it's actually like another view of your own community and your own backyard, wherever you kind of choose to practice medicine. So that's essentially what EM is, even though a lot of people think it's a lot of procedures. Yeah, we do procedures, but a lot of it is counseling. And I can say that I probably saved more lives talking to patients than I have necessarily cracking their chest open. So our daily routine, it involves a lot of shift work. We do not necessarily work in a call system where we're called into the hospital for certain cases and stuff like that, like surgeons might be. We actually receive a certain number of patients when we show up to work from the previous team. We see those patients, and then we see the patients who come into the emergency department. We determine whether we want to admit them, observe them, or discharge them, and then we sign out at the end of the day. So at the end of the day, after you're done with sign out, you don't necessarily have to carry that patient anymore because it's someone else's responsibility. So it's kind of like a team player, teamwork, handoff system. We see everyone at any time, at any day. It was actually kind of one of the things that made me choose this particular topic that we're going to be talking for our cases about, because I think it's interesting that we don't necessarily discriminate against anyone, whether they have insurance, whether they don't have insurance. All we want to do is the best for the patient at that time and make sure that they're not ill. So there's a lot of research opportunities. There's a lot of, there's some lab work, but most emergency medicine doctors went into the field because they like talking to other people. So there's a lot more clinical kind of research opportunities available. And then recently with the pandemic, especially, there are also virtual opportunities available. So talking about some of the common presentations to the emergency department, I think of the top 10 presentations that I see, Shortness of breath, chest pain, abdominal pain, trauma, and fevers are a lot of them. A lot of patients come in very, very ill, but not necessarily requiring procedures, but requiring you to think about what is going on to come up with a plan of care for the patient based on a differential diagnosis. That's how medicine works, essentially, is we go off of theories, and then we try to figure out, okay, is this what we think it is? So the particular complaint that I actually have chosen to focus the majority of the clinical discussion for this talk is shortness of breath. So I'm going to give you guys a case, and then we're going to alter it throughout the presentation to kind of see if you guys can guess what is going on with the patient. So we have a 50-year-old who's presenting for shortness of breath. The vital signs, so that's the heart rate, the blood pressure, the temperature, and the pulse oximeter are all okay. So, you know, he's completely stable clinically is how we would essentially call that. Medical history, well, this guy, he's like, nah, like, I don't usually go to the doctor. I don't take any medications. He doesn't have any medical history. Surgical history, well, he doesn't have any surgical history either. He's never really needed to go to the ED or anything. So this is actually quite common for what we're seeing right now, which is a lot of young patients or younger. 50 is still young in my mind, of patients who are coming in requiring kind of immediate attention. But this patient is relatively stable, so you would see them and then kind of figure out what to do. So I just wanted to kind of put in like a little point about how we view patients. So this patient, one of the things that I would ask for if someone else were evaluating the patient before me, say like a medical student, for example, would be, oh, okay, but what about their O2 sat when you walk them? Because we're seeing a lot of exertional kind of hypoxia these days. So that's one of the kind of added vital signs that I've added to my evaluation of shortness of breath, and that you should definitely consider that just because a patient is stable sitting, when they're walking and standing up, there might be some drop in their oxygen saturation. So going forward, there's actually also the use of the pulse ox has become kind of a controversy in terms of some of the companies might read a little bit differently for different color skin tones. The darker skin tone is, the lower it might read, or the higher it might read. And also, if you have nail polish on, it's not going to give you an accurate saturation. So sometimes you'll see patients at the hospital and they'll put the pulse ox on their ear. The way it works is it's measuring tissue perfusion with oxygen through a certain period of time. So even if you use your ear, you're still able to calculate that rate of perfusion. Just a note for you guys, this was a recent kind of controversy, is the racial bias with pulse oximetry. I think that the way that the oximeter was read was a higher number, so it indicated less hypoxia in a patient who was of a darker skin tone. So less of these patients were detected by the medical system as having hypoxia, even though when their blood work was done, their oxygen levels were the same as a white patient whose like pulse oximetry was much lower in actual detection. So just a note for you guys. Okay, so but going back to the original case, so we have a 50-year-old, shortness of breath, stable vitals, no significant past no surgical history. You do a oxygen while they're walking, and it's okay. So what are the things maybe we want to do next is we want to keep an eye on their vitals, maybe put them on some monitoring to kind of assess how they're doing during their length of stay in the emergency department. Maybe we want to get an EKG to see, okay, is it something cardiac causing their shortness of breath? We want to get a chest x-ray because a chest x-ray could aid us in kind of identifying different pathologies that are happening. We might want to get some lab work if you're if you're not really sure about what's going on, sometimes lab work can help us assess if we're seeing, a really high inflammatory markers or stuff like that. It can kind of help guide us to the fact that the patient in fact has something maybe infectious going on, and an exertional saturation, as we said. One of the other things that we want to add, and that I'm here to teach you guys about, is the idea of using point of care ultrasound in addition to all of these things. So point of care ultrasound is an amazing tool that we have at bedside. We're able to not use any radiation really, because ultrasound waves are relatively benign. We're able to get a faster diagnosis. We're able to treat the patient and also maybe diagnose the patient at bedside if we're using point of care ultrasound. So that's where I come in, and that's why I'm here to kind of help you guys talk through this case a little bit better. So in order to kind of see how point of care ultrasound can be used in this particular study, we're going to go to an article inside Insight. So there's been a lot of enthusiasm about using lung ultrasound given the current pandemic. There's a lot of, I think, people who are very, very much so excited to see the fact that ultrasound is used more, and also that it might be able to actually give us signs for a certain pathology. So essentially, this article came out, I think, like in December 2020, and it's when, why, and how to use lung ultrasound during this pandemic, and what things we should think about in terms of hesitations. So I'm going to actually kind of go through it a little. It's a challenge for clinicians to actually diagnose patients with COVID-19 pretty early on. Still, as of yet, we still don't have like one symptom that's like, oh my gosh, this patient definitely just 100%, no matter what, if you run the test, it's going to be 100% sensitive. But lung ultrasound can definitely aid us if you have a patient who's borderline hypoxic and they're maybe going to be admitted or not. So the study came out of Italy. What they did is they looked at the CT analysis of patients with COVID-19 and said that, hey, most CTs are going to say the same thing when it comes to patients who have this, and it's going to show bilateral peripheral ground glass opacities. So what they did is they said, hey, why don't we go ahead and look at how ultrasound fits into all of this? So they kind of listed out potential scenarios for the use of ultrasound. So at home, the advantages of having a lung ultrasound is that it's quick, easy, and it's there. And you're able to really kind of see if there's any changes, and if someone knows how to use the ultrasound at home in the lung tissue. The second thing is in the emergency department, we use it for everything, but emergency physicians, especially of our current generation, are better trained to kind of use this ultrasound as kind of looking at this diagnosis as opposed to other diagnoses, which we're also going to talk about. In terms of internal medicine physicians, when you admit a patient, when they come into the hospital, if they're sick but not sick enough to be in the ICU, they usually go to something called the floor unit. And when you admit them to the floor, if internal medicine physicians are apt at using a portable ultrasound, they're actually able to look at the lung and not just look at daily chest x-rays to see if there's any progression of disease. Chest x-rays are like one picture, and CTs are like thousands of slices of the same patient. But ultimately, an ultrasound, you don't have to expose the patient to as much radiation, and you can do it on a more regular basis to get more than just one picture that you're getting in the morning of that AP portable lung ultrasound. So that's how internal medicine physicians could possibly use it. In terms of the ICU, you could be used for risk stratification, especially if you have someone who's very sick. You can monitor for very quick changes, like if you put them on certain ventilator settings and say they popped a bleb or suddenly had air outside of the parenchyma of their chest and that pleural space called the pneumothorax, you're able to actually use the lung ultrasound to diagnose that. And I'm hoping to, at kind of the end, to show you guys what the ultrasound images look like on a butterfly. So breaking down its use, ED, prompt isolation and treatment. In the IM ward, you can identify severity. I'll talk about B-lines in a little bit. In the ICU, you can monitor for disease progression. And at home, you can go with someone who's maybe not at their height of illness, and you saw them in the ED maybe on day 3, and now they're at day 7, and they're doing a lot worse, and their ultrasound clearly shows changes that would kind of prompt them to come back to the ED and get further evaluated. So it's very, very, very useful. So how we actually do a lung ultrasound, there's certain fields that we're looking at when we're looking at the lung ultrasound. So this is kind of one of the many different kind of ways to do it, but essentially you want to look at as many views as you can and different areas of the lung. The right side of the lung has 3 lobes and the left side of the lung has 2 lobes, because you have your heart on that side of the lung. So as long as you can see like these lobes and in these different images, that's the important part. For this particular method that they proposed, you're looking at above in the kind of anterior area, in the axillary area, and in the posterior area, all in the kind of superior portions of your lung. And then later on, you're looking at the bottom parts of your lung in that diaphragmatic area of the right side and left side, and then right above the diaphragm on your posterior side. So it's super useful to kind of have, no matter what you do in medicine, it's really useful to have a system for yourself in order to make sure that you don't miss diagnoses, and that you also are able to actually interpret things systematically. So if you're ever in an ultrasound rotation or you're in the emergency department, I encourage you to do something in a way that's understandable to you, whether that's you always do the anteriors before you do the axillaries, or you do the whole right side before you do the left side, whatever works for you. Just make sure you do it systematically so you can look at all of these areas. So just quickly talking about COVID-19 and what it might look like on an X-ray or on a CT scan. There's a couple different types, and they look significantly different on CT scans, which might kind of affect your interpretations of these different types on a ultrasound. So we're not necessarily going to go delve deep or anything, but I just want you to know there's different types out there. So most of the stuff that I'm going to tell you is going to be more general and that you can apply to most patients. So just looking and comparing, I really like this image because it kind of shows you CT images and how they correlate to ultrasound changes, which is why you're here today, to learn ultrasound maybe. So here you can see that between 2 rib spaces, there's not really much going on. It looks like fairly normal parenchyma of the lung, which is the actual like lung tissue. And as you kind of progress with the CT findings here, you're starting to see some ground glass opacities. You're starting to see some kind of interstitial fluid buildup, causing a little bit of reverberation artifact called B-lines. So now you're starting to see B-lines in B. And then when they're coalesced, like here, that's a term that some researchers coined the waterfall sign. So that's another sign that this is actually not looking so great for the patient. This looks okay, and then as you progress, it starts to get worse and worse. And here, you're starting to see that in these earlier images, you can barely see the visceral pleura against the parietal pleura. And as you get more and more inflammation and infection, these kind of become thicker and appear thicker on your ultrasound. So here you're starting to see discontinuation of your pleural line, consistent with a process that's going on, likely COVID-19 pneumonia. And then here, you're starting to see this air bronchograms with subpleural consolidations. These are all official and fancy terms for saying that you're seeing more bad things. And you can see that the CT scan, this is a normal one, it doesn't look good at all. So this person probably has very, very severe disease, and it's clearly seen on an ultrasound. So if you didn't have these images available, let's say you're working in the middle of nowhere land, I don't know, America, and your CT scanner is down. And you go in and you listen with your stethoscope and you're like, I don't know, I hear some crackles, I hear some rails, I'm not quite sure. Seeing is believing. So you may as well just pop the ultrasound on there and see what you find. And these images are actually pretty easy to acquire, and that's why I wanted to show you guys that in a little bit. So there's different aeration zones, and if you have coalesced B lines, that's where you get the waterfall sign. So I wanted to go through, I taught you guys a little bit about lung ultrasound and how it applies to a particular case, but how do you differentiate it from other cases? Like, there's a lot of different causes for shortness of breath. COVID-19 isn't the only thing out there causing shortness of breath in people. And before the pandemic, we have been seeing plenty of shortness of breath, plenty of people who came in for various pathologies. So I kind of altered the situation a little for you guys in these different case presentations so that we can kind of go through one by one to show you guys how the difference is. So now I have a patient who's 50 years old. The vitals are still stable, but the patient kind of just doesn't look like they're breathing properly, and you're hearing rails on their exam. They have a history of heart failure and they're on diuretics. So this automatically should kind of trigger you to, this doesn't sound really like an infectious process. Maybe it could be still, but this sounds like maybe that they're not diuresing properly. And I'm going to add to that. Oh, by the way, this 50-year-old guy, he is non-compliant with his medications. So, when your heart isn't working the way it should be and pumping the way it should be, and you're on a particular medication so that you can kind of stave off some of the fluid so that your heart can continue to function at its maximal capacity, and you're not taking the medications for that, likely you have a fluid buildup in your lungs. So this kind of leads to cardiogenic pulmonary edema as a possible source of shortness of breath and for this guy. So this guy, if you look at his ultrasound, this is what it's going to look like. So this is a little different than COVID-19 pneumonia that I showed you guys earlier. If you guys look at it, so basically here you see kind of B lines going throughout. They're homogeneous, they're not heterogeneous. Heterogeneous meaning variable appearance of those lines. They're usually separated, but they could be coalesced in very, very severe cases. And then you can see these reverberation artifacts kind of penetrating through. And then you usually don't get a compressive atelectasis, meaning you don't get collapse of the lung unless you have a lot of fluid within that lung cavity. And here, sometimes you can get buildup of fluid inside the lung. This is the lung tissue, and outside of it, all of this anechoic area or this black area is actually fluid for pleural effusion. So this is cardiogenic pulmonary edema. This would be the like most common scenario that we would find, but most sometimes if you're able to, you could see a pretty good pleural effusion. If he hasn't been taking it for like, say, I don't know, 3 months, then you might see something. The thing we worry about with cardiogenic pulmonary edema is a lot of these patients will not only get fluid buildup in their lungs, but they'll get it kind of all areas of their body, so including the heart. So this is the emergency medicine diagnosis for bad things are happening right now. And this is an echocardiogram of the chest that we can obtain also at bedside very rapidly. And you can see that normally there shouldn't be all of this stuff around. I'm gonna go back. There shouldn't be all of this stuff around the heart. That's all fluid. And then also the heart is pumping. The pressures of this fluid around the heart are so great that it's causing the heart wall to collapse inward at a time that it's not supposed to collapse inward. So this is a perfect example of cardiac tamponade, which is an emergency diagnosis that we need to intervene on ASAP. Otherwise, essentially the patient can arrest, and you don't want that happening. The treatment for cardiac tamponade is to, in the more stable cases, you can refer them to CT surgery, and they can get a cardiac window, which is essentially something to drain out all this fluid in their pericardial sac. Or in the emergency setting, if a patient is arresting and you see this at bedside, you go in with a large needle and a syringe, and you drain it at bedside, called a pericardiocentesis. Okay, so great. Okay, so that was kind of a little bit of coverage for that patient who's coming in with a history of heart failure. So the next patient, similar guy, they could be friends, but he's a 50-year-old guy too, and his vitals are okay. And he has a history of COPD, but he's been taking his medications. He's doing okay in that sense. At bedside, he's not doing great at bedside though. Like in his chart, he looks great. And at bedside, you go up to him and you could see that he's in a significant amount of distress. And this is what the chest x-ray looks like. So this is just for reference. This is a normal chest x-ray, and his chest x-ray looks like this. That is not good. So this is a classic example for you guys of ARDS. So likely, if you look at all of the kind of findings, they're going to be different for ARDS as opposed to COVID-19 pneumonia that we were talking about earlier, and cardiogenic pulmonary edema, which we were also talking about earlier. So here you can see separated and often coalesced kind of lines here. This gradation is a little bit higher. There could be some small peripheral consolidations, and usually if they have a pleural effusion, it's not very large. But you can see here that the lung tissue doesn't look homogeneous, but it doesn't necessarily have any of those clearly defined little markings for like air bronchograms or anything. So usually this is what ARDS looks like, more irregular, more fragmented. At the beginning of COVID, a lot of people kind of combined those terms, and I think now there's a little bit of more clarity on the specific findings for ARDS versus COVID-19 pneumonia. Although there is significant overlap, because you can definitely get irregularities and fragmentation. So next diagnosis for you guys, or next kind of review for you guys. So the third guy, also 15 years old, 50 years old, same gang. Vitals are stable. However, this patient does have a history of HIV, and their main thing is that they're just coughing a lot and a lot of stuff is coming out. So we call that productive sputum. So for this patient, they don't have any surgical history either. And okay, so shortness of breath, all of the same stuff. This is a normal x-ray that we talked about earlier. When you get bacterial pneumonia, you get something called a consolidation. So here you can see that there's clearly like an area that's covered with bacteria. And then here you have viral pneumonia, which affects viruses are host dependent. So they don't necessarily congregate in one area. They just kind of go all over the lung. So you get more interstitial findings in viral pneumonia. And then in COVID-19 pneumonia, you get those classic brown glass opacities, which you can kind of see haziness all over. So this guy with HIV, his COVID swab was negative yesterday. It was negative today morning. He went in, but he continues to have this cough. He has probably bacterial pneumonia. So basically, you don't really get as many B lines. You might get it at that one spot of consolidation, but generally, you get this change in the actual lung tissue here. If you have a pleural effusion, it's actually, if it's adjacent to the area of consolidation, it could be an empyema, which is a term for a bacterial buildup next to a certain area. So here, you see how this lung tissue looks like very similar to the other tissue around it. Oftentimes, if you're measuring at the right upper quadrant and you see the kind of way the appearance of the lung looks very similar to the way that your liver looks, this could be called hepatization of your lungs. So essentially, that's a fancy term for saying your lung looks like your liver and it shouldn't look like your liver. So this is another example of kind of the lung changes you can see in a patient with shortness of breath. In this case, this patient got diagnosed with bacterial pneumonia and we treated them with antibiotics and all was well. Okay. The last kind of finding for you guys to kind of compare COVID-19 pneumonia before I show you guys COVID-19 pneumonia is pulmonary fibrosis. This is actually like a chronic disease. The shortness of breath will be more chronic. They'll have a history of pulmonary fibrosis. They'll have a pulmonologist. The thing that we don't usually see a lot of like contiguous B lines in this. There's usually more separated B lines or those reverberation artifacts that we talked about. And then the other interesting thing with all these other things like bacterial pneumonia, cardiogenic pulmonary edema. Cardiogenic pulmonary edema usually happens a little bit more at the basis, usually because gravity, you're like usually sitting up, so fluid likes to collect to lower down. With chronic interstitial lung disease, it's when you do imaging of the lung, it's usually throughout the lung. So you'll see changes throughout it. And in very rare and advanced cases, you might see a little bit of a pleural effusion, but not often. All right, so interesting that we got to see all those different things all in a lung ultrasound. And now I wanted you to put it side by side next to the guy that we have come in, and he doesn't have anything that looks like this, or this, or this. Maybe something that looks more like this with the irregular and fragmented, like the ARDS picture, kind of findings. And you could see that he has that reverberation artifact that goes all the way through the B lines. And then here, a lot of the times, if these patients have a pleural effusions, they could be bigger. So here, that's like what you're seeing is a pleural effusion right here. So these are kind of all of these different pathologies, which I thought was cool to show you guys in a patient, in a sample patient who comes to the ED. And I actually really like this image because you can learn so much from just like one table. And we went through so many different cases with one table. Limitations of using ultrasound in general to diagnose COVID pneumonia. There's still no robust evidence of exact diagnosis. It all depends on how skilled your actual sonographer is with using a lung ultrasound. And the other thing is we still want to be very careful until we really have a way to treat COVID. We want to limit our exposure to people who might be infectious. So a lot of even sonographers who might have access, it may still be hesitation even now. Okay, so takeaways, it can be used in different, ultrasound can be used in different clinical settings. There's different clinical criteria versus sonographic findings. Okay, so this is the more fun part, I think. I'm going to very soon stop sharing my screen so I could show you guys some images via ultrasound. So when we talk about the lung ultrasound, we're looking at different lung fields, like I showed you earlier. In the first, like kind of a take on anatomy. A lot of you guys are pre-meds, and you guys all know that you have a rib cage, which encompasses your your chest cavity, and there's certain structures within your chest. There's the heart, and then there's the lungs, and the lungs are easily visualized between your rib spaces. You can't visualize lungs through the ribs because ultrasound beams are sound waves, and sound waves don't travel very well through bone. They travel well through liquid, which is why we use ultrasound jelly in order to help us visualize structures, and they don't also travel as well through air. But what we're gonna do here is the classic bat wing sign that we're gonna be seeing on a ultrasound of the lung. We have two rib spaces right here. Right here, this line is actually the pleural line. So the way it moves is usually you'll see kind of a little bit of reverberation here, and then this will be a sign that your lung is moving up and down in the pleural space as you actually breathe, and that is normal. If you don't see it moving up and down, then we have a problem. It might mean that there is air in that space, which is a indication that you might have a tension pneumothorax and that you might need other intervention. As you can see, rib, you'll see rib shadow behind the rib, and then rib shadow behind the rib. And then the actual lung itself will have an artifact, an ultrasound artifact called A-lines, and then there's soft tissue on top. Okay, cool. So let's try it out. I'm going to zoom in through my phone, and I'll show you guys. Stop sharing, and then, all right, meeting. Sorry, I tried this out just prior to. Shadowers. Okay. And after this, I'll give you guys a little bit of advice, and I'll open it up to Q&A.
Would you like me to send you the link again?
I got it.
Okay.
It's on. Okay. Cool. Awesome. And okay. All right. Awesome. And you can see this, and then share content. Let me share my screen. Start broadcast. All right. You guys should be able to see my screen. And then here is the Butterfly app. So let me just do this for you guys. So I'm gonna try to show you guys images. So I have my ultrasound probe. Let's see, my lung cavity, it's in that. So, okay, so here you see a very hypertrophic area. Get that perfect view for you guys. Okay, cool. So here, I just kind of moved my probe up and down, and I have to the right-hand side right here on my screen, you have a rib shadow, and the left side is a rib shadow, and here is your pleural line. Can you guys see where I'm marking? I hope so. Okay. And I'm going to take a deep breath in, so you can actually see the movement of, so you see how there's a drop off, rib shadow drop off. I'm sorry, it's really hard to do. And this line right here is the line that I'm looking at when I'm breathing. Let's see if I can get a better image. There, right there. You see that at the very top? That's your visceral and your parietal pleura. And then you can do this in different lung fields. I'm wearing clothes, so I'm not going to do that. But you can scan it. You can scan up to your clavicle, which is what I'm at right now. I'm scanning down, and then you see that clear movement right here at the very base of something else. That's probably my heart. Okay, guys, that's my heart. I don't know what you want. Let's see if I can get a better image. And it's really hard to image your lung over your heart. There's very little lung over it, but you can see actually what's coming into view. Let me flip it so I can actually explain it to you guys. No way. This is actually my left ventricle right here, which is the biggest chamber of the heart. That's easy to visualize. I'm going to show you my right lung as well. You see that clear movement? Can you guys see me pointing at the screen? I hope so. Of lung tissue underneath. These are rib spaces with rib shadowing underneath. Other things I could show you guys. So this is my neck. I'm gonna drop it a little, drop it. Not that much maybe. And here you could see vessels in your neck. Let me put some color Doppler over here, so you guys can see where my vessels are. Yeah, I should just take it off for a second, and once I find it. When you're, I did want to show you guys something. So when you've isolated a good space between your rib spaces, what you can do is you can actually do something called M mode, and you can take this line, and here I'm just breathing normally and trying not to move, and decreasing. Trying not to move, trying not to move, trying not to move. This right here is actually called the stratosphere sign, or the barcode sign. It looks kind of like a barcode. It's actually, sorry, not a barcode. It looks like waves on a beach right here. You see waves on the beach, and this indicates that you have reverberation artifact throughout your lung as your lung is moving, so it's moving properly. If you see a barcode, which is very well striped without all these interferences, then it's actually a sign that you might have lung tissue that's not moving. Other things you can do is take that off. You can actually, okay, those were the main things, I think. And I wanted to see if I could find my vessels for you guys. Maybe they're so superficial. Okay. But this is where you would insert a central line usually, if you have. I have strap muscles around this area. Usually you'll see pulsating things. Let me see if I can find another vessel on my hand maybe, so I could just show you what color Doppler looks like. I'm imaging my wrist, by the way, right now. So you could see like different articular surfaces. You can actually can't see throughout my wrist because there's actually bone. And I'm very, very deep right now. I want to say that's a vessel right there. If we put color over it, should see pulsating. There you go. This is my radial artery, which isn't very well visualized. I'm not even in the right application for it. Okay. But I thought it was cool with the lung, at least. You guys got to see something kind of cool. And I'm going to move on with the presentation and stop this share. Let me stop sharing my screen. Stop sharing my screen back to me. And then I want to finish off the presentation. Okay, we tried it out. Tips for you guys. So I think that it's really important as a pre-med that you guys like have a lot of interest and a lot of time and a lot of enthusiasm to learn. And that's actually what's going to take you forward more than necessarily like how smart you are or how high your scores are. So essentially, being willing to learn is like the number one most important thing that's going to help you throughout your career, no matter how much you feel about. Can you guys see my presentation? I just realized how you guys feel about the different things that you might not like a particular subject. Being willing to learn is super important. Being a team member in every sense is also really important. Medicine is actually really, really collaborative. It's not necessarily like all competition. We have a very large community, and honestly, it's smaller than you think. A lot of people in different fields even like know each other. Engage in leadership opportunities. A lot of medicine, you'll be required to, do different leadership things. Foreign language is very useful. You don't need to study a lot more than other people. You need to study effectively, meaning like the things that you learn, actually retaining those pieces of information. Next is 5 more tips. So I would find good mentors that are going to be there for you throughout the whole process, no matter if you're pre-med, in medical school or in residency or even beyond. I think that it's the number one most important thing is to have the appropriate people who are helping you achieve your dreams. Do not lie, especially to other people in medicine. It's not cool. And also, if you're like a student presenting to an attending and you just didn't do something, I respect the fact that you say, I didn't do it, or let me go do that, instead of you like making up a value for something that maybe you didn't do. Failure will make you stronger. I'm sure a lot of you guys, same like everyone else, haven't succeeded in every single thing that you've done ever. But in medicine especially, I think that you have a lot to learn from every patient, and even a small mistake, you have a lot to learn about like yourself and your knowledge from that. Hard work will show. If you come early, if you leave late, that's going to leave a great impression on other people. What goes around comes around. Also, like I said, don't ever, just be kind. Just don't be a dick. And I think that it will actually serve everyone really well if we're all like a collaborative. This is how to reach me. You guys like want to connect with me on IG or Twitter or whatever. I actually do have a blog from way back when I was in medical school, from 2013 to 2017, kind of detailing like my experiences and things that I learned on various rotations. And I think it's kind of cool if you want to look forward to your future, what that may look like, to do that. And that is like pretty much my presentation. I'm not sure if you guys had any questions. Let me put it in the, let me look at the chat. Okay. Okay, so is ARDS seen besides in relation to COVID-19? Yes, ARDS is seen, it can be seen in COVID-19 and not in COVID-19. We've been seeing ARDS for many, many years, even prior to COVID-19. Aside from a chest x-ray, how can a physician diagnose bacterial versus viral pneumonia? Someone asked what the purpose of gel is for. The purpose of gel is that sound waves do not travel well through air or solids. Liquids are actually the best kind of the way that sound waves penetrates. So that's why if we don't use gel, you won't really be able to see anything, because there's always going to be a lot of layers of air between my tissue and the ultrasound. And in terms of diagnosing bacterial and viral pneumonia, the whole thought process behind that is that it's caused by different agents. Viruses, generally there is PCR tests. There's different tests that you can kind of do for a diagnosis. I guess the only way to know is to get a specimen for sure. So bronchial alveolar lavages, where you actually get the sputum and like kind of suck out all the mucus from the tissue, will help you with the diagnosis as well if you want to get the actual tissue for diagnosis. There's a lot of ways that you can. Also, you can just run a test for literally everything now. So there's tests. Unfortunately, there are tons of viruses, and so literally you can't test for exact type of virus unless it's one of the most common ones, but there are tests for many different types of things. Can this ultrasound work on the back too? Yeah, it can work on your front, your back. As long as it's not a solid bone that's covering the area of interest, because with bone, you saw that behind the bone, it's just purely shadowing. How accurate are these compared to the ones used at the hospitals? Unfortunately, most hospitals, you're not allowed to use handhelds in the setting of documentation. Like I'm billing for this ultrasound because I did it. It's more for education that currently handhelds are being used. The accuracy is more so like having like a TV that's really crisp and clear versus like an old school TV, like where, you know, there's really grainy or whatever. It's kind of like that, where they're not quite at the same level as a lot of the great huge machines that you have. How long is your ultrasound and fellowship, and who would the requirements? Ultrasound fellowship is 1 year. You can a majority of the people who do ultrasound fellowship are emergency medicine trained, meaning they went to emergency medicine residency. However, some of them are from the internal medicine division. There's a couple of fellowships that apply for that. The requirements are that that you are of one of those specialties, and like anything, just that you graduate residency and that you have an interest in the actual field that you're applying to. A lot of the times, like people will look for like research or other activities to show that interest. How long is your ultrasound? Okay. How long is emergency medicine residency? Emergency medicine residency is 3 to 4 years, depending on what program you go to. Some of them are 3 years long and some of them are 4 years long. The one I attended is 3 years long. How do you get a good mentor? Okay. Why did I choose emergency medicine over other specialties? I think emergency medicine is just one of those specialties where you can really do everything. It's like the best 5 minutes of every field. Like you name a field and it's literally the best 5 minutes of that field. Like, for example, like, I don't know, like anything. Like, it's just fun. Like, for example, rheumatology, like the best 5 minutes is draining that joint. And for me, I don't know, that's the most interesting thing. And then I don't have to do all that outpatient workup. All I'm doing is the acute management. So I see a lot of questions about mentorship. This is a really, really, really tough time to find good mentors. Ideally, a mentor is someone who can help you and guide you to the place that you need to be. In medicine, a lot of this times it comes at like kind of your next level of training. So for pre-meds, maybe that's like a medical student, maybe that's like a resident, maybe that's an attending. Sometimes it's your peers as well. The best mentors are those who offer themselves up to be mentors in your, if you can think of any people who you've shadowed or who you have come in close contact with that, you know, you particularly connected with, those are the people who might be able to help you out the most because they know you the best. I think approaching someone to be your mentor is, most people are fairly open to mentorship. It's just weird if it's not in your field, or it's like if someone isn't going into medicine and someone asks me to be their, I don't know, like business mentor, I would not be the appropriate person. I think identifying the ideal person, like if someone was like, hey, I want to go to medical school. Okay, yes, like definitely I've been through that path. I know how to get there. And that's like how you do that. I've had many mentors in my life. I've been very lucky. I think that in terms of mentorship, my first mentor was one of my TAs for a class I took in undergrad. And it wasn't even in the same field. It was more, hey, how do I get into grad school? Like, how do I do research? How do I study for classes? Like stuff like that. So I think at the pre-med stage, if you guys have any TAs for your classes, those would be good people because they also want to mentor. And also TAs sometimes know people who are of their, like who might be their friends in the same areas as you guys or in the same institutions as you guys, who might be able to help you guys out. So I think TAs are a good place to start. A lot of professors are very I went to a public school. A lot of my professors, I felt like, had a billion people approaching them for mentorship at any given time. Unless there's something you're really doing extra for that class or that particular subject, it's really hard to get that kind of same feeling, especially if you're in a public school. If you're in a private school, it might be totally different, and maybe you don't have TAs, maybe you only have professors, and hey, go for that. Okay, so what are some of your favorite cases? My favorite cases are, I like peds. Peds for the most part is very rewarding. The thing about I find about peds is generally children don't have a very extensive medical kind of history. Like, they're not on like 50 billion medications, and a lot of the times when they come in with complaints that you feel like you fix. Like, a patient comes in, bead is stuck in his nose. You get out the bead, they feel better. Mom is like, you're a genius, and you feel very good about that. Most adult emergency medicine physicians, if you're practicing in an academic site, might not see that many children because usually there's an adjacent children's ER. If it's just if it's like in the community, I would say depending on the community, but usually less than 20%. So usually 10 to 15 is my guess, but don't mark me for that. It depends on how close the largest children's center is and stuff. And I also was asked, like, my favorite cases, I really like things that sometimes I can fix immediately. And I also really like critical care. So things I can fix immediately, like, I don't necessarily like lacerations, but I think foreign body removals are really fun. Like a cockroach in the ear, you get it out, you feel good about yourself, the patient feels good and stuff like that. What was my favorite part about attending medical school? Well, I think the most fun part is every single day is so different. Like first year you're learning anatomy, second year you're like studying a lot, but then you get like sometimes you get some exposure to the clinic, and then you're like, oh my god, today I saw rheumatoid arthritis. I saw this clinical sign, and it was on my like it was on one of my questions, and this is crazy. And then third year and fourth year are honestly, I loved being kind of in the clinic. I didn't really enjoy too much of the time necessarily like just studying. I think like interacting with people like really like gave me a lot of joy. And I think like every single rotation was amazing on its own, delivering babies, treating children, treating adults, anesthetizing people. It was all great. So I really enjoyed medical school, and I think match day is coming up for a lot of people. So you guys are going to see a lot of people posting their joys about that. And that was actually one of my favorite days. It all depends on where you go and what you do. But at any point, you can always choose to be happy, even in medicine. That's it for now. I think that's all the questions that I had in the chat.
Thank you so much for presenting for our web shadowers again. It's always a pleasure to learn from you. And thank you so much for showing us the live ultrasound. It was super cool and interesting to see.
Yay. I'm glad you guys enjoyed it. I feel like I wish I had more time, because then I could have gone through more applications and had it preset on the butterfly. But I'm really glad you guys got to at least see the lung applications. And now when you approach a patient with an you know what you're looking for, and it's going to make you guys look awesome for your EM rotations.
Everyone thought it was super cool. Thank you.
All right.
Everyone, make sure you check out her socials. Her Instagram is Hey Siri MD. And the link to today's Google form is now posted in the chat box, and it'll be in the description of this video at the end. So please fill it out within the next 30 minutes for us to receive verification of your attendance. Again, thank you so much, Dr. Chamarti, for presenting for us again. It was wonderful to have you.
Yeah, thanks. I'm glad I could be here, and I'm glad you